Hi everyone, welcome to today's pediatric class on Docemy. Today we will be discussing about Kawasaki disease, KD. So Kawasaki disease is usually asked as a short note question. It can also come as an essay question with different sub-questions to it. So let's start today's class with a case of 2-year-old Sham who presented to your OPD with history of fever for 6 days and irritability for the past 4 days. He has a generalized rash, he has conjunctival congestion of his oral cavity. He is immunized till age. There is no contact of any similar illness in his family or in the neighborhood. On examination, he was febrile. There was a pulse rate of 130, otherwise his vitals were stable. There was a single right cervical lymphadenopathy which was significant. There was conjunctival congestion without any discharge. There was a red tongue with cracked lips and a generalized maculopapular rash. Otherwise, his system examination was normal. Just hearing this case, you've got only one diagnosis on your mind, and that is Kawasaki disease. So, is it that simple to diagnose Kawasaki? Maybe not. Let's just go to the theory now. So, again, as in all classes, we will be going through this topic under these headings. Now, do you see this very senior pediatrician, Dr. Tomisaku Kawasaki? It was him who described the disease, the constellation of the symptoms, and gave the name Kawasaki disease to this constellation of symptoms. He was a Japanese doctor. He actually he was the one who described the disease and let the world know that there is a disease like Kawasaki. He unfortunately died in June 2020. So with that note, we will start today's class. So what is the definition of Kawasaki disease? It is a vasculitis. It is a vasculitis that affects the medium-sized vessels. Okay, it is a vasculitis that affects the medium-sized vessels, and it is usually seen in childhood. So, it is a childhood disease and not a disease of adulthood. Okay. It was earlier called the mucocutaneous lymph node syndrome or the infantile polyarthritis nodosa. It is the most common cause of acquired heart disease in children. The most common cause of acquired heart disease in children, and is the most commonest, the commonest of the childhood vasculitis. Now, let us go to the epidemiology of Kawasaki disease. Usually, this is a disease seen in the Asian population, especially in Japan. So, it is a disease especially seen in Japan. Okay. The incidence of Kawasaki disease in Japan is much more, is the maximum in the world. It can be seen in other races also. It is a disease of, I told you, early childhood, that is less than 5 years of age. 80% of the children are affected less than 5 years of age, and of this almost 50% are under 2 years of age. So, any child who is less than 3 months and more than 8 years, it is unlikely that their disease is Kawasaki. And in the present context of COVID, there is a Kawasaki-like syndrome which is happening in the older children and adults, and which is known as the multi-inflammatory syndrome in children. Okay, the MIS, that is something else. So, the epidemiology, it is a disease of males. So, two rheumatological diseases which are more common in males, one is Kawasaki disease, another is HSP. Others, all other rheumatological diseases are mostly common in females. Now, let us go into the etiology. Again, as for all rheumatological diseases, the etiology is unknown. Infectious causes are postulated because of this constellation of symptoms like conjunctivitis, there is a lymph node, fever, rash and all that. Genetic predisposition can be there, and also it is seen in families. Immunological, because there is a vasculitis, there is an inflammation by the immune response that is happening. Along with an environmental trigger such as an infection or some other trigger, these genetic and immune systems, there is an interplay of all these factors here. Now, let us go to the pathology. The key word in pathology is the necrotizing vasculitis. Necrotizing means that layer of that vessel is being destroyed. It affects the medium size. Again, next keyword is coronary artery. So, coronary artery is keyword here because it is the main vessel that is involved and cause most of the complications. Well, what is actually happening here? I told you it is a necrotizing. So, if there is a vessel wall like this, there is a the layers of the vessel wall, there is destruction of this internal elastic lamina. This internal elastic lamina is going to get destroyed. So, that elasticity of the vessel is lost, and so there is the outpouching or an aneurysmal formation that is happening. So, if the aneurysmal formation is on the side of the vessel like this, it is called a saccular aneurysm. Okay, saccular aneurysm. Sometimes the whole of the vessel wall is destroyed and the whole of the vessel wall can go aneurysmal, and this is called a fusiform. Just the name, that shape, how it shows, no? The fusiform aneurysm. And when there is a destruction of the vessel wall, you know, your platelet, von Willebrand factor, they form complexes and a thrombus is formed. A thrombus is formed here. When a thrombus is formed, there is obstruction of flow of blood, which can lead to, if it's a coronary, it can lead to myocardial infarction. Or after this inflammation, vasculitis has settled down, there will be a fibrosis and stricture of that part of the vessel. So, coronaries are not the only vessels that are affected. Other vessels that are affected are your axillary artery, your popliteal artery, your femorals. All these can be also affected in Kawasaki disease. Now, coming to the clinical features. Again, the clinical features are divided into three phases. You have a acute phase. Okay, the first 1 to 2 weeks you have an acute phase. In the next 2 to 3 weeks you have a subacute phase, and 6 to 8 weeks you have a chronic phase. So, now let us see what happens in each phase. In the acute phase you have that febrile phase where fever will be there, your congestion will be there, your lymph node will be there. All these comes in the first phase. In the second phase, you have your peeling, okay, desquamation happening. When desquamation happens, your peeling happens, and your platelet count increases. This is a thrombocytosis. We know platelet is an acute phase reaction, so there is a thrombocytosis that occurs, and your coronaries are going to get affected in this phase. Your coronaries are going to get affected in this phase. The chronic phase is when is a convalescent phase, that means the inflammation has come down and the fibrosis is setting. So, you get your stenosis, your thrombus formation, because there is an aneurysm, the thrombi formation, all that happens in the last phase. Of these, the worst phase is the subacute phase, because if not properly treated, it is where your coronaries are going to get involved, and once the coronaries are involved, there is no going back. It can regress, but that is not a good place to be in when your coronaries are involved. Okay, now coming to the criteria. So, this is a star question, that is a frequently asked question. So, the clinical features in Kawasaki disease are a frequently asked short note question and sub question of an essay. So, what is the criteria? The essential criteria is presence of fever for at least 5 days. So, at least high grade fever should be present for at least 5 days to diagnose Kawasaki. Along with that, there are 5 other criteria that should be met. Okay, so for diagnosing the essential criteria plus 4 out of these 5 criteria should be met to clinically diagnose Kawasaki. So, Kawasaki is basically a clinical diagnosis and not a lab diagnosis. Okay, so what are the other 5 criteria? Bilateral non-purulent conjunctivitis. Non-purulent means it is not an infection. So, there is no discharge. It is a non-purulent bilateral conjunctivitis. We will come to the details later. Oropharynx, oral cavity and oropharynx changes, that is congestion of the lips, congestion of the oral cavity, strawberry tongue and all that. Changes in the peripheral extremities again can be acute changes and subacute changes. Acute changes in the first week can be the erythema of the hands and feet, edema of the dorsum of the hands and feet, and subacute changes are the periungual peeling that occurs. Then the fourth one is the polymorphous rash, the generalized rash that can occur, and then you have the cervical lymphadenopathy. If any 4 out of these 5 is positive with 5 days of fever, you can diagnose Kawasaki. Especially in children less than 6 months, you should be very careful. And another criteria that should be met, these things should not be explained by any other disease. Suppose you take an example of scarlet fever, or you take an example of IMN by Epstein-Barr virus, the infectious mononucleosis, they can be for 5 days, they can be oral cavity changes, they can be edema, they can be rash, they can be cervical lymphadenopathy, but that will be explainable by IMN. So, that should not happen in Kawasaki disease. Okay. Now, let us talk about the fever. Usually it is a high grade fever, more than 101 degree Fahrenheit. It should be continuous. So, high grade, continuous are the key factors, that is unremitting. Unresponsive to antibiotics because and analgesics, because it is an inflammation that is occurring, not a prostaglandin involved thing, there is no infection. So, it will not, because there is no infection, no action of antibiotics, because there is no prostaglandin, no much action of analgesics. Duration, usually if not treated, spontaneously resolved by 2 to 3 weeks. Sometimes it may take even longer. It is a prolonged, usually presents a fever of unknown origin, where you get, you don't know the cause. Okay. So, that is a character. So, it is a high grade continuous fever not responding to your antipyretics or antibiotics. Now, the eye changes. I told you it is a conjunctival congestion that has occurred. So, both eyes, here there is only one eye, so you can imagine another eye here. So, both eyes are affected. There is congestion, there is no discharge. See, there is no discharge here. Clear eyes, congestion, and this perilimbal area. Can you see this area there? There is no much congestion in that area. Perilimbal area is spared. Oral cavity changes, usually there is erythema of the oral cavity, of the tongue, of the lips, the cracking of the lips may occur, but there will be no ulceration. It is also known as the strawberry trunk. Okay. Strawberry trunk, there are two DDs, one is your Kawasaki disease, another is your scarlet fever. That is why it is very difficult. Scarlet also can present with rash, with high grade fever, but usually when the rash appears, the fever comes down, and when you give an antibiotic, the fever comes down in scarlet. So, can you see the strawberry here? All this, you know, see the same consistency, you see this, all these papillae. The papillae are the seeds of the strawberry, and the red tongue is what is called a strawberry trunk. Can you see the cracking here? Cracked lips, congested oral cavity, red lips, you know, as if he has put on lipstick. So congested the lips are. Now, the extremity changes, I told you there are acute changes. In that first week, the changes will be erythema of the hands and feet and edema of the dorsum. And in the second to third weeks, you get the periungual peeling. Very important, periungual peeling. Okay, here you can see the periungual peeling. It starts from the tips. Even in scarlet you will get peeling, but usually scarlet peeling starts anywhere from the palms and goes to the periungual. Here it will start, it will be like a sheet of skin coming out. Okay, can you see that sheet of skin coming out here? That sheet as well is coming out. So that is periungual peeling. Here you can see the dorsal edema here. Okay, edema is what is seen in this picture. Now coming to the rash, it is usually a polymorphous. It can be in any type of rash can come. Usually you see the maculopapular rash. Scarlatiform rash means a rough rash, a papery, the papery rash, and you can also find erythema multiforme. That means the target like lesions, erythema multiforme like lesion. They are non-pruritic, there is no pruritus, mainly on the trunks, and the groins are usually affected. There is a erythema basically affecting the groins, the perineal lesion, there is an accentuation there. They can be desquamation. Perineal desquamation is a very characteristic feature of Kawasaki. You can also get perianal desquamation. So, here you can see that erythema of the hands. Here you can see the generalized maculopapular rash. Okay, this is the rash. Perianal desquamation, very characteristic feature, and the perineal accentuation in Kawasaki disease. Cervical lymphadenopathy. What are the characteristics of cervical lymphadenopathy? It is usually non-suppurative. That means there is no signs of inflammation. Only one side, unilateral, specifically the anterior cervical triangle will be involved, and the size will be minimum. So, it should be a single node more than 1.5 centimeter to use as a criteria for diagnosing Kawasaki disease. Now, let us go to the other features which are not very consistent, not very common, but the BCG scar induration is a very characteristic finding seen in Kawasaki. That means your BCG scar will again become inflamed, it will be raised and indurated. Extreme irritability, it can be due to they can be arthritis, they can be pain, can be due to the fever, they can be aseptic meningitis also, which is causing irritability. Hepatitis can occur. Gallbladder hydrops is a finding that you can get in the USG of the abdomen if you take one. Arthritis, and less commonly urethritis and meatitis can occur, which can lead to sterile pyuria. CVS is a very important organ, and the most dreaded organ affected is your coronary artery. So, coronary abnormalities, aneurysms can form. Okay, you can have, I told you, the saccular aneurysm, the fusiform aneurysm, there can be a thrombus formation, fibrosis, strictures, There can be giant aneurysms. Giant aneurysms are ones that are more than or equal to 8 millimeter in diameter. All layers of the heart can be affected, okay, and peripherally also it can affect the vessels such as Raynaud phenomenon, gangrenes can occur. So this is the arteriography picture where you can see multiple aneurysms have occurred in the coronary arteries, okay. Now coming to some terminologies in Kawasaki disease. Till now we were discussing about the clinical features, the criteria, different criteria. Simply a fever cannot be there. What is the criteria for fever, criteria for rash and all we said. Now coming to terminology. What is typical KD? Typical KD is diagnosed when there is fever plus 4 out of the 5 criteria in the absence of any other illness to explain the same. What is atypical KD? Usually atypical KD and incomplete KD are used synonymously, but exactly they are not synonymous. You can use synonymously, but when you get a question, you can in OP Guy and Nelson, they have been mentioned synonymously. So when there is a synonymous definition for both, it is called as it is defined as a fever for less than 4 days duration. We told no fever has to be there for less than 5 days. Okay, so either fever for less than 4 days duration plus your echo findings. If echo findings of aneurysm is that, you can diagnose as KD, or if there is less than 4 criteria out of 5. If 4 criteria is not there, only less than 3 or less than 3 criteria are there, with fever you diagnose it as atypical or incomplete KD. But in the real sense of the word, atypical KD means if there are atypical features like atypical GI involvement, CNS involvement, other systems involved, other than that 5 typical features. Incomplete KD is basically this, if there are less than 4 criteria to meet. Node first KD means the child presents only with fever and a single lymph node. So you can diagnose it as a suppurative lymphadenitis sometimes, or you may diagnose it as TB. Okay, so that is node first KD. Other features will come later. And KD shock syndrome is where there is severe myocarditis, that the patient will go in for a cardiogenic shock. Okay. So the criteria for diagnosing KD, one is fever for 5 days with 4 out of the 5 criteria, or fever for 5 days with less than 4 criteria. If it is there, you can diagnose incomplete KD. If less than 4 criteria is there, you can either use something what is known as the supplementary lab criteria. We will be coming to that. Or if there is an echo evidence of coronary aneurysm, you can diagnose KD, especially in children less than 6 months. Okay, with prolonged fever, you should always do an echo to rule out Kawasaki disease, fever and rash. Now there are 2 scoring systems. These are just bonus points. You just have to know the names. These are the scoring system for the risk factors. So risk factors, the poor prognosis is usually seen in male gender. Okay, younger age, that is less than 1 year, male gender, if there is a coronary aneurysm that has occurred, these are all poor prognostic factors. So 2 scoring, from the name you can understand these are Japanese scoring. So the Harada scoring system and the Kobayashi scoring system, just to prognosticate risk for developing coronary artery aneurysm. Differential diagnosis can be any infection, viral infection, EBV, CMV, adeno. Okay, all these can be measles, again rash, fever, measles, okay, can be a DD. Bacterial infections, your rickettsial infection, scarlet fever, staphylococcal scalded skin syndrome, all these can be toxic shock syndrome, all this can be DD. Rheumatological, SLE, JA, SOGIA, systemic onset JA can be a DD. And others like I told you, toxic shock syndrome, drug rash and all that can be differential diagnosis. The investigations are not very important because I told you Kawasaki is a clinical diagnosis. CBC, as for any rheumatological inflammatory diseases, your total count, there is going to be leukocytosis. In the first week, your platelet count is going to be normal. In the subacute phase, 2 to 3 weeks, you are going to get thrombocytosis. That is a key word here. Thrombocytosis, 2 to 3 weeks, even up to 10 lakh, more than 10 lakh, it can go. ESR will be elevated, CRP will be elevated, plasma lipids may be elevated. You may get hypoalbuminemia and hyponatremia. So these are 2 supplementary criteria that you can use, hypoalbuminemia and hyponatremia. Then your there can be transaminitis, your SGPT, liver enzymes will get elevated. I told you there can be urethritis, meatitis, so you can get sterile pyuria. What is sterile pyuria? There are WBCs in your urine on urine examination, but culture is negative. That is sterile pyuria. So it's not due to infection, it's due to inflammation. CSF counts will be increased, pleocytosis will be seen. Everywhere there is inflammation, wherever there is medium vessel. Troponin I, if there is carditis, myocarditis, your troponin I is going to get increased. USG abdomen can show hydrops bladder, hydrops of the gallbladder, and echo, very important. Any child you are diagnosing Kawasaki, one echo should be taken immediately and a repeat echo should be taken after 2 weeks in the subacute phase, because that is where your coronaries are going to get developed. So at diagnosis and at 2 to 3 weeks to look for coronary aneurysm, and if there is no aneurysm, you have to follow up after 6 weeks, 6 months and yearly. If there is aneurysm, you may need frequent follow up according to the aneurysm size. Okay, so you can get this, usually there are scores known as the body surface adjusted, body surface area adjusted coronary artery diameter scores, okay, which is known as the Z score. So you will compare the child's Z score with the Z score and see if there is coronary artery dilatation or aneurysmal formation. Now the supplementary criteria I told you, this is used to diagnose when all the criteria of KD is not met. So you have the sterile pyuria, hypoalbuminemia, hyponatremia, anemia, CPT elevation, on all that. Now going to the treatment, again a frequently asked question. So treatment can be divided into 3. Treatment in the acute phase, treatment in the convalescent phase, and treatment for IVIG refractory or resistant cases. So acute phase, the treatment drug of choice is intravenous immunoglobulin or the pooled immunoglobulin or IVIG. The dose is a high dose, 2 milligram per kilogram given over 10 to 12 hours. So this is the dose of IVIG. You should, if there is and because it is an inflammation, you should give an anti-inflammatory, because this is immunoglobulin to actually that immune to target the immune response. You have to give an anti-inflammatory, and aspirin initially you have to give in an anti-inflammatory dose. Anti-inflammatory dose of aspirin is high dose, antiplatelet is low dose. Anti-inflammatory dose 30 to 50 milligram per kg per day. This is the only dose which is given in OP. In Nelson, both these are given 30 mg per kg per day or 8, even higher dose 80 to 100 mg per kg per day given Q6 hour in divided doses, 4 divided doses. Okay, till 48 hours of defervescence. Till there is no fever. 48 hours there is no fever. Till that you give this. After that, after 48 hours, you can bring down your dose to the lower antiplatelet dose. Okay. And if suppose there is an acute coronary, this is angina or an MI like acute coronary thrombosis, you have to give your fibrinolytic therapy. If it in the convalescent phase, that is after 48 hours of being febrile, you are bringing down that aspirin dose to our antiplatelet dose of 3 to 5 mg per kg given as a single dose for 6 to 8 weeks. That is for the inflammation to come down. Now, if there are coronary abnormalities and if there is an aneurysm, there is always a chance of thrombosis. So, in that case, you have to give prolonged antiplatelet therapy. Aspirin again in the antiplatelet dose of 3 to 5 mg per kg OD. Then another antiplatelet is clopidogrel, which can be given in the dose of 1 mg per kg per day for a maximum of 75 mg. And if there is there has been a thrombosis, you have to give low molecular weight heparin or warfarin to that child as anticoagulation. Third step in treatment is the treatment of refractory KD or IVIG resistant KD. That means you are given IVIG but the inflammation has not come down. When you say that the patient has refractory or IVIG resistant KD, if there is persistent fever or recrudescent, that means fever has come down and again come, that is what is known as recrudescent fever, 36 hours after the first dose of IVIG. What will you do then? In that case, you can give a second dose of IVIG. Okay. With that second dose, if the fever does not come down, you can give IV steroids. But steroids does not have any additional dose. Some people give steroids along with the second dose of IVIG. Okay. So IV methyl also you can give in a high dose, inflammatory dose, 20 to 30 milligram per kg. You can give, if that also does not work, your third line will be your infliximab, the anti-NF alpha inhibitor infliximab. You may also have to add immunomodulars like cyclophosphamide. So in refractory cases, first step is second dose of IVIG, then you have come to your methyl steroid, methylpred is not working, you are going to infliximab, that is not working, you are going to your immunomodulator. Plasmapheresis can also be done because it is an immune mediated process, but it is not very helpful. Now, what are the complications of Kawasaki? We know the most dreaded is coronary artery aneurysm. Coronary artery aneurysm, thrombosis. It can lead to myocardial infarction, angina, and sudden death. So, this is the dreaded complication. Even in older life, the patient, young myocardial infarction, if you take a history, you might get a history of suggestive of Kawasaki. This is a fever or rash in the childhood. So, it is very important that scoring. So, usually the coronary artery aneurysm, the prognosis, usually the coronary artery aneurysms come down by less than 3% of children will have complications by 1 year. Okay, 1 year, if it's a small aneurysm and all, if it is less than 5 millimeters, aneurysms are spontaneously subside, and by 1 year, if you take an echo, it will become normal. But giant aneurysms rarely they can come down in cells but rarely subside, and you may have to go for surgical therapy in those cases. Untreated patients, almost 15 to 25% of children go for coronary aneurysm. 1 to 3% can have recurrence. If properly treated, adequately treated, they can have a good prognosis. So, when should you adequately treat? Treatment should be initiated by at least 10 days, preferably by 7 days. Maximum by 10 days, then only your IVIG is going to help, because by after 10 days already the insult has occurred. By 2 to 3 weeks your coronary artery aneurysm is going to happen. Now let us come back to our case. Okay, so this is a case of Shyam, who presented in the OPD with history of fever for 6 days and irritability for 4 days. So he is having a prolonged fever, high grade fever, okay, 6 days, and he is irritable. So, what are the key points here? Fever, irritability, generalized rash, conjunctival congestion without discharge, oral cavity changes. There is no other illness. He is immunized, so not measles, no other illness. On examination, single cervical node, criteria 1, conjunctival congestion, criteria 2, oral cavity changes, criteria 3, general maculopapular rash, criteria 4. 4 criteria along with fever. So, this is a case of Kawasaki disease. So, now we will go and rule out the DDs. We will see if there is any carditis, system examination. You look for the rash, you will describe the rash in detail. So, with that, we have come to the end of today's class. Now, we will go through 2 or 3 MCQs to see if we have really understood the topic. Now, what is the most commonly involved vessel in Kawasaki? What is the most commonly involved vessel? Yes, the medium sized vessel, of that the coronary artery. Coronaries. The coronary arteries are the more commonly involved. All the others, aorta will not be involved in Kawasaki, but popliteal can be involved, femoral can be involved. Which statement is false about Kawasaki disease? Affects the coronaries causing aneurysm. Is that true or false? It's true, right? We were talking about coronaries and aneurysm all this while. Gallbladder hydrops can be a presentation. True. It is a less common manifestation. IVIG is a drug of choice. That is also true. So, what is false? Presents with purulent conjunctivitis. What does it present with? It presents with non-purulent bilateral conjunctivitis. The following are seen in Kawasaki except. When you do MCQs, no, you should be very careful for such terms, because there will be double negatives to confuse you. So, this is except. Okay. So, anemia is seen in Kawasaki? Yes. Thrombocytopenia is seen? We'll keep that there. Hyponatremia? Yes. Hypoalbuminemia? Yes. Is thrombocytopenia seen? No. Usually what is seen? Thrombocytosis is what is seen in Kawasaki disease. With that, we come to the end of today's class. Hope you have understood Kawasaki, understood the concept. Hope you'll remember the criteria. Till we meet next time, it's bye. Happy learning.
Docemy.